Welcome to this explainer, everyone. Look, if you are a stressed medical trainee currently staring down the barrel of your upcoming board exams, you are in exactly the right place. Today we're doing a rapid-fire, ultra-high-yield review of Coccidioidomycosis. Most people just call it valley fever. We're going to target the exact buzzwords and sneaky clinical traps those examiners absolutely love to throw at you. Okay, let's dive into this.
Here's our game plan for today. We'll start with etiology and endemic zones, move into clinical presentation and rheumatism, then dissemination in high-risk groups, high-yield diagnostic markers, targeted treatment and relapse, and we'll wrap it all up with the top clinical board traps.
Now picture this. I want you to keep this classic board vignette right in the back of your mind as we go through the material today. A construction worker in Arizona develops a cough, joint pain, and a sudden eosinophil spike. What is your next move? If your instinct is immediately reaching for standard community-acquired pneumonia antibiotics, hold that thought. Let's break down why this specific patient is actually telling you a completely different story.
Section 1. Etiology and endemic zones. The desert villain. So, coccidioides is what we call a thermal dimorphic fungus. It's basically a shapeshifter. It changes its form depending on its environment. Out in the alkaline, arid soils of places like the San Joaquin Valley or Arizona, it lives as Arthroconidia. These are highly infectious, barrel-shaped spores that get easily aerosolized whenever the dirt gets kicked up. Think construction sites or archaeological digs. But once they're inhaled into the warm environment of the human lungs, they transform into the tissue form, which are called spherules. You absolutely must memorize this word. Spherules are massive. We're talking up to 200 micrometers, and they are just packed to the brim with reproducing endospores. If you see a spherule on a biopsy, that is completely pathognomonic for coccidioides.
Now, listen to me very carefully on this next point, because this is a major trap warning. If you even suspect coccidioids, and you decide to order a culture, you must warn the laboratory in advance. Culturing this fungus is a severe laboratory hazard because those infectious Arthroconidia easily become airborne right off the petri dish. It strictly requires BSL-3 precautions. Sending this down to the lab without a heads up? Yeah, that is a massive board fail.
Section 2. Clinical presentation and rheumatism. Beyond community-acquired pneumonia.
So it's actually really important to note that about 60% of patients who get this are entirely asymptomatic. They never even know they have it. But for the 40% who do get sick, you are frequently going to see the term desert rheumatism pop up on your exams. This describes a patient presenting with symmetric arthralgias, usually in the ankles, knees, and hips. And this often comes along with erythema nodosum, which are those intensely painful red nodules on the lower legs, particularly in female patients. So the crucial point is this. Erythema nodosum and those joint pains represent a robust immunologic response. It means the patient's cellular immunity is actively fighting off the infection. It absolutely does not mean the fungus is disseminated to the skin or the joints.
So how exactly do you pivot your vignette diagnosis away from just a run-of-the-mill bacterial pneumonia? Well, you look for these specific clues. The patient will very often have peripheral blood eosinophilia. That is a highly specific, flashing neon sign for coccidioides. They'll also stubbornly fail to improve on standard antibacterial therapy. On imaging, you might spot an upper lobe infiltrate or maybe some hilar and mediastinal lymphadenopathy. And clinically, they're going to complain of really profound night sweats and just overwhelming marked fatigue.
Moving on to Section 3. Dissemination and high-risk groups. When the fungus spreads.
Now, while only about 1% of infected patients ever experience actual dissemination of the fungus beyond the lungs, examiners test incredibly heavily on exactly who falls into this bucket. You need to be able to fire off these high-risk demographic and immunosuppressive groups in your mind the second you read a clinical vignette. Dissemination is statistically far more likely in males, and very specifically in individuals of African or Filipino ancestry. Obviously, any cellular immune defect like AIDS with a CD4 count under 250, or patients taking glucocorticoids and anti-TNF therapies, they are at very high risk. But do not miss this one. Pregnancy, specifically late pregnancy in the second and third trimesters or the postpartum period, is a massive risk factor for disseminated disease.
And hey, another quick board alert here. If the test question describes a pulmonary nodule, remember that calcification is highly uncommon in coccidioides. Do not confuse this with the hallmark, heavily calcified lung nodules you usually see in histoplasmosis. If that nodule isn't calcified, you need to keep valley fever right at the very top of your differential.
Section 4. High-yield diagnostic markers. The serology gauntlet.
And this brilliantly illustrates the exact diagnostic algorithm you must commit to memory.
First, we screen with an enzyme immunoassay, or EIA. This checks for both IgM and IgG, and it's great because it's rapid and sensitive. Next, we look at the specific antibodies. The 2-precipitin, or TP test, looks for IgM. Because IgM is always our early responder, a positive TP means you're looking at a recent acute infection. Then, we have complement fixation, or CF. This one tests for IgG, which is the later responder. If you see rising CF titers, that tells you the fungus is actively growing and the disease is actively progressing.
Now, I want you to literally burn this specific complement fixation titer number into your brain. 1 to 32. If you ever see a CF titer of 132 or higher, that is a massive, screaming red flag. It indicates severe, widespread disease and an extremely high risk of extrathoracic dissemination.
If the worst happens and the disease disseminates to the meninges, causing coccidioidoidal meningitis, it is uniformly fatal if left untreated. If you do a lumbar puncture, the CSF is going to show lymphocytic pleocytosis, hypoglycemia, which is just a fancy way of saying low glucose, and elevated protein. But you want to know the real giveaway? Finding eosinophils in the CSF. Seeing even occasional eosinophilia in the cerebrospinal fluid is an absolute dead giveaway for a fungal or parasitic etiology.
But to definitively, absolutely prove it, you need the gold standard. Finding that CF antibody directly inside the CSF is the single most specific diagnostic test for coccidioidal meningitis. If you see that finding on your exam, the diagnosis is totally locked in. No question.
Section 5, Targeted Treatment and Relapse, Triazoles and Timelines. So for a lot of your otherwise healthy, immunocompetent patients with just mild primary pulmonary disease, you actually just observe them. They often don't even need antifungals. But when the disease does spread, boards absolutely love to test your ability to match the right drug to the right location. If the patient has bone and joint disease, itraconazole is your preferred drug. It's actually proven to be more effective than fluconazole for that osteoarticular spread. However, if the patient has disseminated or meningeal disease, fluconazole is your preferred first-line therapy. You might be wondering about amphotericin B. Well, that's primarily reserved as a last resort for severe, critically ill patients or when triazole therapy completely fails.
And when you are treating meningitis with fluconazole, you do not mess around with standard low-level dosing. You need a massive 800 milligram daily dose just to penetrate the central nervous system effectively.
And exactly how long do they have to take that giant 800 milligram dose? Look at this. If you stop treatment for coccidioidal meningitis, the relapse rate is a terrifying 80%. Because of those odds, treatment for meningitis is strictly a lifelong commitment.
Let's move to and see how this builds into Section 6, Top Clinical Board Traps, our final rapid-fire review.
Pay really close attention to this diagnostic order of operations, guys. Step 1, always screen with the EIA first. Step 2, confirm a positive screen with immunodiffusion. Step 3, once it's confirmed, you must request that CF titer titer to check for severity. And remember, 132 or higher is bad news. Finally, Step 4, you monitor that CF titer over time, because that number should steadily decrease as your treatment actually starts working. Do not let the exam scramble these steps and trick you.
I'm going to leave you with this final, provocative thought. Imagine a patient who is actively on therapy. Their CFT titer is actually dropping nicely, which means their pulmonary disease is visibly improving. But suddenly, they develop a severe headache, and a lumbar puncture shows that their CSF is now full of eosinophils and falling glucose. What is your diagnosis? Look, their lungs might be getting better, but those CSF markers are screaming coccidioidal meningitis. It means the fungus has quietly disseminated to the brain, and they need that lifelong 800 milligram dose of fluconazole immediately. Always keep your eyes completely open for the full clinical picture. Thanks so much for joining me on this explainer today. Study hard for those boards, and I will catch you on the next one.